Good afternoon and welcome to the fourth webinar of 2021 in the ACCP Immunology and Transplantation PRN webinar series. My name is Lourenco Jenkins and I'm currently a medical science liaison at CareDx, and as some of you may know, came to CareDx with a background as a transplant pharmacist, and it's my pleasure to moderate today. Today's webinar is titled Updates in Pharmacogenomics and Non-Invasive Diagnostics, and we are honored to have Dr. Kayla Joyall and Dr. Shirley Tsunoda present for us today. Dr. Kayla Joyall earned her Doctor of Pharmacy degree from Northeastern University in Boston, Massachusetts. She completed her PGY1 pharmacy residency at the University of California, San Francisco Medical Center, followed by a PGY2 solid organ transplant residency at Massachusetts General Hospital. Kayla now practices as a solid organ transplant clinical pharmacy specialist at Lahey Hospital and Medical Center in Burlington, Massachusetts. Dr. Shirley Tsunoda is a professor of clinical pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences at UC San Diego, where she teaches therapeutics, conducts clinical and translational research, and provides patient care in the liver transplant clinic. Her research focuses on investigating factors that influence the variability of narrow therapeutic range compounds, such as immunosuppressive agents. She's also actively investigating the intersection of the microbiome and drug metabolism, as well as using the skin as a matrix for detecting drugs. She received her bachelor's in psychobiology from UCLA and her doctorate in pharmacy from UCSF. She completed a PGY1 residency at UCSF and a postdoctoral research fellowship in pharmacokinetics and drug metabolism, also at UCSF. In a moment, I'll turn it over to Dr. Tsunoda to begin the presentation, but first, here are a few quick notes. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We will take questions at the completion of the presentation. There will be an evaluation for this webinar available at its conclusion, and we encourage you to complete this to let us know how we did and how we can improve our webinars going forward. Also, the slides from today's presentation will be posted on the ACCP website in the section titled Webinar Slides after the presentation. If you experience any technical difficulties during the webinar that are not fixed by logging out and refreshing your internet connection, please make the presenters aware through the chat functionality. There's also a live chat on the upper right-hand corner of your screen where you can get live technical support from any meeting. So now, without further ado, I'll turn it over to Dr. Shirley Tsunoda.
Thank you so much, Laura. And I just want to thank Ricky and the ACCP Immunology Transplant PRN for the invitation to talk with you today about pharmacogenomics and basically what's new. So I thought today we would start with a patient case to kind of put things in perspective. I'm going to briefly talk about the current guidelines with tacrolimus and CYP3A5, which you probably are all familiar with. I'm not going to talk about azathioprine with TPMT and NUD-T15, but just to point your attention that there was a 2018 update to azathioprine on the CPIC website. And so if you're interested in refreshing your memory about that, there's a nice algorithm for how to approach pharmacogenomics with respect to azathioprine and the new NUD-T15 gene. We're going to talk about some emerging research with tacrolimus and PGP. And then we're going to focus a little bit on MMF today and all of the different transporters and enzymes with particular respect to UGT that has emerged, and briefly talk about the donor-recipient mismatch that exists when we do liver transplant. Then we'll come back to our patient case, and we'll also discuss clinical implementation. So let me introduce you to my patient. So AR is a 20-year-old woman with PSC, and she received a right lobe living donor liver transplant from her uncle. Her post-op course was relatively uneventful. She received standard immunosuppression with tacrolimus, mycophenolate, and a prednisone taper, which is our standard protocol here at UCSD. And at her next ambulatory visit, she hands you a printout of her 23andMe genetic report. And among other things on that genetic report, you notice that she has CYP3A5 star 1 star 1 and ABCB1, or the gene that encodes for PGP-CC genotype. So just to refresh your memory and review for a second, to point out the intersection with the intestine and the liver with respect to drug metabolizing enzymes and transporters. So when a patient takes an oral medication, obviously it goes through the intestine, and we can have PGP activity pumping of that drug out of the enterocytes back into and back out of the enterocytes, allowing another opportunity for the compound to get into the systemic circulation, or it can just be lost. The compound can be further lost by intestinal drug metabolism, and when we talk about many of our immunosuppressants, we know that CYP3A4 is present in the intestine, in the gut wall, and we can lose some drug to intestinal metabolism, and that's before it even gets to the liver. Then the drug moves into the liver, and we can lose some drug due to hepatic metabolism, such that, as you all know, dealing with our immunosuppressants, most of the drug gets lost, and sometimes we only get about 30% of bioavailability, for example, with tacrolimus. However, as you all know, there's a lot of variability with that. So some patients have 90% bioavailability, and some patients have, 4% bioavailability. And we really don't know until we start drawing levels what their metabolism is going to result in. So I'm sure you're all familiar with the CPIC guideline with CYP3A5. And with our patient AR, she is star 1, star 1, which means she expresses CYP3A5. So the wild type is actually a non-expressor of CYP3A5. And so she expresses CYP3A5, which means I kind of like to think of it as a supercharged CYP3A, which means she's kind of like a rapid metabolizer. So that's going to lead to lower tacrolimus concentrations. And according to the CPIC guideline, if we were to a priori test her genetics before we were to start her on a starting dose, we would actually increase that starting dose by 1.5 to 2 times the recommended. And then with respect to peak glycoprotein, remember that's the intestinal pump, and this is what I'm showing you on this slide is kind of what happens to the drug when we're talking about the genetic polymorphism in the intestine. You obviously have PGP throughout many of our organs in our body, such as the liver, the brain, the kidney. But we think that most of the effects on bioavailability occur with respect to the intestine. So when you have a genotype like our patient AR, she has the CC genotype, and that encodes for a protein that has increased activity. So that means her pump is working harder and it's pumping more drug out of the intestinal cells. And that allows either for the drug to get excreted in the feces, or it also allows CYP3A to have another opportunity to metabolize the drug prior to it getting into the systemic circulation. So the end result is that we have decreased absorption of tacrolimus. And you can see with the other genotypes, if you are heterozygote for CT, then you have kind of a moderate activity. But if you have the TT genotype, then you have decreased activity, which means then you'd have increased absorption. But with respect to our patient AR, she has the CC genotype. So that means that if we take those two things together, she has star 1, 3A5. So she has that supercharged 3A, which means she's a rapid metabolizer. And so she's going to rapidly metabolize tacrolimus. and possibly need a higher dose. And we also know that her ABCB1 or PGP genotype is CC, which means she has an increased activity of P glycoprotein in the intestinal wall, meaning there's going to be more drug pumped out, meaning less drug available. And so again, potentially she might require a higher dose of tacrolimus. So now we're going to move on to 5 months later. So now she's 5 months post liver transplant, and her liver enzymes are rising. And a liver biopsy shows acute cellular rejection. She's also been experiencing diarrhea, which she associates with her CellCept. And we do additional pharmacogenomic testing, and we see that she has a variant in the UGT enzyme. And you remember UGT is a glucuronide. So it's that phase 2 metabolism, which is important actually for mycophenolate. So we're going to kind of switch gears now and kind of look at her mycophenolate metabolism. So she has a particular variant in UGT1A9. So this is kind of a complicated slide. So what I want you to just kind of focus on for a second is all of the different enzymes and transporters that are responsible for MMF metabolism. So there are a lot of transporters involved, and this upper panel is the intestinal cell. So you guys all know MMF is a prodrug that requires activation in order to become active to mycophenolic acid. That occurs in the intestine. And there is some intestinal metabolism that occurs by virtue of the UGTs. Then we have the liver cell here in the middle, and we have various other UGTs. We also have some cytochromes that are involved in mycophenolic acid degradation. And then at the very bottom is just showing the pharmacodynamic effects of mycophenolic acid. And there has been some research with IMPDH variants that I'm not going to talk about in detail, but we'll kind of summarize at the end. So let's focus on UGT1A9, and that's seen in this red rectangle. So UGT1A9 in the liver is the most important liver UGT enzyme that's responsible for glucuronidating MPA. And what's important to remember about that is that glucuronide then gets dumped into the biliary system, and then it travels back into the intestine where the gut microbiome has bacteria that can deconjugate that glucuronide and create active MPA again that then gets transported back into the intestinal cell. And that MPA is active, right? The MPA is active drug. So that can actually impact while the glucuronide is not active, because of this process of enterohepatic recirculation, that can impact the activity of mycophenolate. And so our patient has this particular variant that has been shown to increase activity. So that variant encodes for, again, kind of a supercharged UGT1A9, which would then lead to lower mycophenolic acid AUC. So if you're pushing more mycophenolic acid to the glucuronide, then we have less MPA available. And there was one study that did show that there was an increased risk for acute rejection and also an increased risk for GI complications, which, as you know, is one of the dose-limiting side effects of mycophenolate. However, there have been there have been several other studies with specifically UGT1A9 that have not found a clinical association with acute rejection or the GI complications. So the data is conflicting. So with respect to our patient, she has this particular variant. So I want you to just focus on the top panel up here. She has that particular variant of UGT1A9, which causes her to create more glucuronide from the active MPA, leading to decreased MPA and a potential for increased rejection risk. Now, I want to draw your attention. I'm just going to give you a little aside because I thought it was interesting. This is not necessarily pharmacogenomics, but I think this is, research that's up and coming that may affect how we use mycophenolate. So mycophenolate has been shown to actually alter the gut microbiome. And you can see that in this panel to the left. It's just kind of a nice, colorful diagram of different bacteria in your gut microbiome. And they showed that MMF actually does alter the gut microbiome and actually causes more bacterial beta-glucuronidase bacteria to form. And remember, with that enterohepatic recycling, it's those bacterial beta-glucuronidases that pull off that glucuronide, deglucuronide the MPAG, and push that back into the active MPA. And so that causes increased MPA, right, in the intestine, which could potentially cause more diarrhea. Interestingly, if we give vancomycin, broad spectrum antibiotic that's active in the gut, it actually inhibits the beta-glucuronidase bacteria and ameliorates the diarrhea. And this was shown in a mouse model. If you can see on this bottom panel, the control group with the lit up of the bacterial beta-glucuronidases are lit up. MMF causes more of them to be formed. As you can see, that it's a little more lit up. And then vanco kind of abolishes those beta-glucuronidases. So it kind of begs the question that we might be using vancomycin, or maybe something not as toxic to our patients, but we may be able to someday manipulate the microbiome to prevent the diarrhea and the other GI side effects that we see with mycophenolate. So just to kind of summarize, there have been investigations with all of these enzymes and transporters involved in mycophenolate metabolism. So 2C8, PGP, MRP2. These PGP and MRP2 are two intestinal transporters. And then the various UGTs that are involved in mycophenolate. And then there are also hepatic OATPs that are involved in uptake of mycophenolate into the liver. And all of these variants have been assigned a level 3 or higher by PharmGKB, meaning there has only been just one clinically significant study that has shown something clinically significant with particular variants of these enzymes and transporters, but that additional studies have been unable to replicate these findings. So although there's been a lot of research with all of these different drug metabolizing enzymes and transporters with respect to mycophenolate and trying to find some clinical association with either rejection or toxicity, the studies to date lack a clear evidence of association with any of these variants, with any of these enzymes and transporters, and clinical outcome. And the same is true for IMPDH1 and 2, which are those it's the target enzyme of MMF or MPA, and associations with the pharmacodynamic effect of MPA. And that has also not risen to the level of clinical significance. So the jury is still out with respect to mycophenolate mofetil pharmacogenomics. So our patient was a liver transplant patient, and as you all know, the liver, when we have our liver transplant patients, there's a particular mismatch between the donor and the recipient with respect to their drug metabolizing organs, right? So they have one genetic makeup of their intestine, their recipient intestine, but then their donor liver has totally different genetics. And so that creates that donor recipient mismatch. So there have been some studies looking at, does the genotype of the donor or the recipient drive the drug metabolism and transport? And there were two meta-analyses done recently that are sort of conflicting. So, is it the intestine that's more important? And is it 3A5? Is it PGP? Is it something else that kind of overtakes the, which genetics is most important in giving us a clinical result? So in one meta-analysis, they showed that recipient 3A5 star 1, so star 1, remember that's the genotype that our patient has, that supercharged 3A, that recipient 3A5 star 1 had the greatest influence on TAC PK immediately post-transplant, but then as the patients got further from transplant, donor 3A5 star 1 allele became more important. So first it was intestinal, presumably, and then as patients got further from transplant, it was the liver 3A5 genetics that became more important. But then there was another meta-analysis that actually kind of found the opposite, that donor 3A5 star 3, so star 3 is kind of the wild type where you just kind of have kind of no 3A5 really, and that influenced the TAC PK in the first week. And then both donor and recipient were influenced at weeks 2 and 4. And there was no clear association with the PGP or ABCB1 genotype with respect to donor-recipient mismatch. Now, I just wanted to point out on the right-hand side this kind of very complicated diagram, because I want us all to think about, not only are we talking about donor-recipient mismatch, but we're also talking about intestine, right? And all of the different transporters and enzymes that are in the intestine. So if we think about tacrolimus, we have PGP, we have CYP3A4, we have CYP3A5, and then in the liver, we have CYP3A4 and 5. We also have various transporters in the liver that tacrolimus is a substrate for. And then we also have the target organ, right? So if it's a liver that's transplanted or if it's a heart that's transplanted, we have distribution to those organs, and we have the pharmacodynamic effects of the drug on the T lymphocytes. And so you can imagine that trying to think about all of these different pharmacogenomic effects, all of the different alleles and variants that patients have between the recipient, between the donor, among the organ, the intestine, the liver, the site of where the organ was transplanted, and then we have the T lymphocytes. So it can actually be a little bit mind-boggling to think, well, we have to combine all of these different variants into a net result of that tacrolimus concentration and the effect of that concentration at the target organ. So it's a little bit of a complex picture. We probably can't just focus on one gene necessarily, but it might be a combination of different variants. And maybe that, for example, with 3A5, there's definitely a strong association with that one, with a specific genetic variant, but that it has to be something very strong like that for it to rise to the level of clinical significance. So let's kind of follow up with our patient AR, and this also kind of illustrates the complexity. So we looked at 3 different genes in AR. We looked at 3A5 star 1 star 1, and that is the only gene that has CPIC guidelines. And for our patient AR, CPIC would say we should increase our starting TAC dose by 1.5 to 2 times the normal starting dose. So she's got a supercharged CYP3A. She also has ABCB1CC genotype. And remember, we talked about that has an increased activity of her PGP. So she might need an increased tacrolimus dose as a result of that ABCB1 genotype. She also has a variant in her UGT1A9 enzyme. And does that maybe increase her risk for acute rejection? And would we need to modify the dose of MMF? The data, suggests that there's not enough evidence for us to do anything clinically with that particular UGT. And then she has a donor-recipient genotype mismatch. So is there a role for donor genotyping? I'd be kind of curious to see if anybody in any of your centers is doing donor genotyping. It is something that has been done in some centers and in the research setting, but I don't believe it's something that's currently being done clinically. I know we're not doing it at UCSD. But again, it kind of gives us sort of a big picture of all the different things that we would need to think about in terms of thinking about the pharmacogenomic variants in a patient on tacrolimus, mycophenolate, and prednisone. So now kind of something about clinical implementation. So all of this, blood drawing or cheek swabbing and checking of genetic variants is, done, all of this that we talked about has been done in the research setting. And if we don't have a way to implement this clinically, then all of this information is sort of for naught, right? And so I know at UCSD, we don't have clinical implementation of pharmacogenomic testing. We're talking about implementing it. It's a huge undertaking, and I'm sure those of you who are at sites that do have clinical implementation of pharmacogenomic testing, you know what a big deal it is to implement that from a data science perspective and then from an education perspective. So I was honored to be part of a study. We actually did two studies, and this was in collaboration with Chris Aquilante at the University of Colorado, where we kind of looked at what are the barriers to implementation in solid organ transplants. So, as you know, we have CPIC guidelines, particularly for 3A5 and TPMT at the time. So why isn't it widespread clinical implementation? Why are more people not a priori testing for all of these different genetic variants, with particularly the ones that have CPIC guidelines? And there are other ones that we use in transplants, such as voriconazole, clopidogrel, warfarin, and you guys all know that there are at least 35 different CPIC guidelines. So these are guidelines that have been vetted, that rise to the level of clinical significance. So why are we not doing this in transplant? So we conducted two studies. We did a prospective 2-center study of 60 transplant patients and providers, where we interviewed them, gave them a survey. We talked to individual patients, and we did a group of patients, and then we did individual providers, PharmDs, MDs, and NPs. And we tried to understand, what their opinion was on pharmacogenomic implementation, and kind of what their level of comfort was, what their educational level was about pharmacogenomics in general, and whether or not they ever ordered a test for pharmacogenomics. And then we also did a national survey of medical and surgical transplant directors, where we surveyed them in a similar way in terms of their educational knowledge of pharmacogenomics, whether or not they order pharmacogenomic testing, and what their opinion was on the clinical importance of pharmacogenomics. And basically, we found out that there's just kind of a lack of appreciation for the impact on clinical practice. So they questioned whether or not, it was important to clinical practice. And these are a few quotes from the study, that the usefulness might be limited due to routine use of PK-guided immunosuppressive therapy. So obviously, we draw levels on TAC and sirolimus, everolimus, and so maybe we don't really need pharmacogenomics. It doesn't really matter what their genotype is, because we're already adjusting based on a trough level. And other people said there was a lack of confidence in the pharmacogenomic knowledge and the ability to apply results, so that they didn't feel like they had the knowledge if they were given a genetic report like a 23andMe, or there's so many of these direct to consumer tests out there now, that they wouldn't know how to interpret that test and they wouldn't know what to do with that information. And then that there was uncertainty regarding the clinical value and also a concern for patient financial burden. So are insurance companies going to pay for this, for these tests? And we didn't want to burden the patient if it wasn't going to be something useful. And then with the national survey, we found that 55% reported pharmacogenomics being available at their institution, but only 38% ordered a test in the last year. And I would say probably the majority of the testing that's done is for TPMT. So something, food for thought for all of you to think about clinical implementation, because again, if there's not a robust implementation through your electronic medical record system, it's going to be difficult for providers to use that information and to apply it to patient care. And it requires quite a bit of impetus and buy-in from your particular institution to do clinical implementation. So in summary, we currently have CPIC guidelines for the immunosuppressives tacrolimus and azathioprine. The pharmacogenomic data for MMF is still emerging. There's really nothing that rises to the level of a CPIC guideline yet. But it's interesting that maybe we'll be manipulating the gut microbiota for optimizing the use of MMF in the future. And then donor-recipient genotype in enzymes and transporters may be important in the liver transplant patient. And clinical implementation remains a challenge. So I'd like to thank you very much for your attention, and I'm happy to take questions at the end of Kayla's presentation.
Hi, everyone. Thank you all for the opportunity to speak today. Non-invasive biomarkers are exciting tools with the ability to provide transplant clinicians with more precise and convenient methods to monitor overall immune function. Given that different centers are utilizing these tests in a variety of ways, from research-based use to protocolized use to potentially no use at all, my goal today is to level the playing field and provide a broad overview of how these assays were designed, how they were clinically validated, and how they can potentially impact our day-to-day practice as transplant pharmacists. I have no disclosures, and the following abbreviations will be used throughout the presentation. By the end of the talk, I hope you will be able to identify non-invasive biomarkers currently available for use in solid organ transplant, be able to compare and contrast the differences between these tests, and discuss the implications of these assays on clinical practice. As transplant pharmacists, we are tasked with monitoring graft function and tailoring immunosuppression to balance risk of rejection, infection, and drug toxicities. We're all very familiar with the routine labs we use to monitor each organ's overall function, with the exception of heart transplant, which unfortunately does not have a great organ-specific biomarker. We also rely heavily on biopsy for diagnostic confirmation of rejection, whether these be protocolized or for cause, and more often than not, these biopsies are accompanied by DSA sampling. Unfortunately, the lab values we rely on for monitoring lack sensitivity and specificity and do not reflect graft injury until histologic damage has already occurred, leaving us relatively blind to what's actually going on in the allograft. Our gold standard biopsy is inconvenience for patients and places them at risk for complications like bleeding, infection, and damage to other organs. These procedures are fairly costly due to the resources they require, and the results are prone to sampling error depending on which particular part of the allograft is biopsied. Additionally, biopsy interpretation is dependent upon individual pathologists who may reach different conclusions. The non-invasive biomarkers used to monitor immune response in solid organ transplant are donor-derived cell-free DNA and gene expression profiling. The three commercially available donor-derived cell-free DNA assays available in the U.S. are AlloSure, Prospero, and Transplant Rejection Allograft Check, or TRAC. TheraSure and OrganTrace are available in Europe and included for completeness, but I will not be discussing these further. AlloMap and TrueGraph are two commercially available gene expression profiling tests in the United States. Cell-free DNA is continually shed into recipient blood circulation from the moment an organ is implanted due to continual cell turnover. Predetermined thresholds and values of donor-derived cell-free DNA have the potential to assist in diagnosis of rejection. Cell-free DNA was first described by Mandel and Matthijs in 1948. About 50 years later, fetal cell-free DNA was discovered in the blood of pregnant women, which led to the development of prenatal diagnostic tests for abnormal chromosomes. These tests were able to replace high-risk amniocentesis to detect genetic abnormalities in the fetus. Oncology has also adopted the use of cell-free DNA to differentiate normal and tumor tissue to identify the presence of cancer-causing mutations, diagnose disease, and monitor response to chemotherapy. The technology platform and method by which each assay analyzes variations in DNA between the donor and the recipient differs between assays. These methods will also likely to continue to evolve over time as science advances. It is important to note that all commercially available donor-derived cell-free DNA assays currently utilize next-generation sequencing, which does not require full genotyping of the donor and the recipient prior to use. When an organ is transplanted, T cells initiate an immune cascade that ultimately leads to apoptosis of the targeted cells. As these cells die, the nucleic acids within them become fragmented, resulting in approximately 120 to 160 base pair pieces of double-stranded cell-free DNA that are released into the blood. Once a company receives a sample of blood to test for cell-free DNA, they use a precise detection to look at single nucleotide polymorphisms, or SNPs, to differentiate between donor DNA, which is represented in red, and recipient DNA, which is represented in black. When they assess how much DNA is from the donor and how much is from the recipient, they look at the percentage or proportion of cell-free DNA. Typically, the percentage of donor DNA in the blood of the recipient should be small, like in the top right picture, but if there is rejection, you would expect to see more donor DNA depicted in the bottom right picture. There are a variety of analytical studies validating each of the aforementioned tests, but I will be focusing on the clinical validation studies. AlloSure is commercially available for monitoring of kidney transplant recipients and through research protocols for heart and lung recipients. Both Prospero and TRAC are validated only in kidney patients. The DART study was the first study to evaluate the ability of donor-derived cell-free DNA to discriminate rejection from no rejection. This prospective, multi-center observational evaluation of 102 kidney transplant recipients reviewed paired blood and for-cause biopsy samples, which are evaluated with Banff criteria at specified intervals. The median donor-derived cell-free DNA in antibody-mediated rejection was 2.9%, compared to 1.2% in T-cell rejection grade greater than or equal to 1B. These were much higher than grade 1A at 0.2% and 0.3% in the control group with no rejection. The positive and negative predictive values for any active rejection at the 1% threshold were 61% and 84% respectively, and for antibody-mediated rejection were 44 and 96% respectively. Based on these results, authors concluded that AlloSure is able to discriminate antibody-mediated rejection from no rejection better than T-cell rejection from no rejection in kidney transplant recipients. Additionally, AlloSure less than 1% reflects the absence of any rejection, where levels greater than 1% indicate a probability of active rejection. After the DART study demonstrated that elevated levels of donor-derived cell-free DNA correlated with organ injury and an increased risk of probability of active rejection, Jordan and colleagues assessed the combined use of donor-derived cell-free DNA and DSA testing to diagnose active antibody-mediated rejection. This sub-analysis included 16 patients from the DART study who met criteria for antibody-mediated rejection and had paired AlloSure and DSA samples available. The median donor-derived cell-free DNA was significantly higher in DSA-positive patients with active antibody-mediated rejection compared to patients that were DSA-positive without antibody-mediated rejection. At the 1% threshold identified in the DART study, the positive predictive value of donor-derived cell-free DNA to detect antibody-mediated rejection in DSA-positive patients was 81%, compared to only 48% of DSA alone. These results support that patients with donor-derived cell-free DNA positivity and positive DSA levels have a high probability of active antibody-mediated rejection. The first external validation study of AlloSure was performed by Huang et al. In a retrospective analysis of prospectively collected data from 63 kidney patients with suspicion of rejection and a donor-derived cell-free DNA sample within 30 days of biopsy. The percentage of donor-derived cell-free DNA was higher among patients with antibody-mediated rejection compared to no rejection, and the cell-free DNA test was not able to discriminate patients with cell-mediated rejection from those without rejection. At a threshold of greater than or equal to 0.74%, the AlloSure had a positive predictive value of 68.6% and a negative predictive value of 100% for antibody-mediated rejection. Authors reached similar conclusions to the DART study that AlloSure is better at discriminating antibody-mediated rejection from no rejection than cellular rejection from no rejection. A second external validation study was performed by Skaggs et al. As a prospective multicenter study of 79 kidney transplant patients with T-cell-mediated 1A or borderline rejection who had a simultaneous measurement of donor-derived cell-free DNA. Patients in the elevated donor-derived cell-free DNA group of greater than 0.5% had a higher more significant EGFR decline, more de novo DSA formation, and future or persistent rejection, supporting that use of donor-derived cell-free DNA may complement Banff classification and help stratify patients with borderline or T-cell-mediated 1A rejection identified on biopsy. The Prospero Method, which was initially adapted from prenatal testing models, was evaluated in a single-center retrospective analysis of 300 blood samples from kidney transplant recipients paired with 217 matched biopsy samples, which were evaluated with modified Banff criteria. At a threshold of 1%, Prospero had a 88.7% sensitivity and a 72.6% specificity for detection of rejection. Investigators went one step further to project a positive and negative predictive value of 52% and 95% respectively, based on a 25% prevalence of rejection. These findings differed from the AlloSure studies, as donor-derived cell-free DNA did not differ between antibody-mediated and T-cell rejection. Authors concluded that Prospero can detect rejection prior to renal failure to help promote optimization of patient management. Unfortunately, there is not as much data available surrounding the clinical validation of the TRAC assay. The Virecor Eurofins lab bulletin reports that 77 plasma samples from kidney recipients were tested with the analytically validated method from a biorepository source. 58 of the samples were collected during a rejection-free period, while 19 were collected during a period of humoral, cellular rejection, or BK nephropathy. A cutoff value of 0.69% was selected based on the ROC curve, and this was found to have a sensitivity, specificity, positive predictive value, and negative predictive value of 58%, 84%, 55%, and 86% respectively. These assays cannot be directly compared due to differences in analytical and clinical validation, but it's important to be mindful of study design and the inclusion criteria when evaluating their utility. Negative and positive predictive value are important considerations in determining the role of non-invasive biomarkers. Assays with a high negative predictive value minimize false negative results, which would be missed rejections, and have utility in minimizing surveillance biopsies. Assays with high positive predictive value minimize false positives and can potentially provide justification for a for-cause biopsy. The strength of the currently available assays lies in their higher negative predictive value, providing opportunity for use in place of surveillance biopsies. All three assays do require blood samples, and Prospero and AlloSure provide results in 3 days, while TRAC has a slightly longer turnaround of 4 to 6 days. These tests are all covered by Medicare and most commercial insurances. Following the validation studies, Hanosa and colleagues shared their experience using AlloSure to successfully monitor response to rejection treatment in 3 patients. Kirkman and colleagues shared a case report of a 72-year-old kidney transplant recipient who was treated with nivolumab for advanced melanoma. This patient's donor-derived cell-free DNA ratio increased to 23% within 12 days after the first administration of nivolumab, and this experience supports a unique role of AlloSure in the monitoring of immune function in patients who are receiving checkpoint inhibitors. Overall, the current data supports a promising role for donor-derived cell-free DNA in monitoring and detection of active rejection, clarification of ambiguous biopsy results, and monitoring response to rejection treatment. When considering the utility of these tests, it's important to obtain a baseline test value and interpret the data as a part of a serial monitoring protocol rather than a single point in time. Unfortunately, these tests are not validated in multi-organ or stem cell recipients, pregnant women, or identical twins. They are not able to be performed within 24 hours of a biopsy or dialysis, as injury from these procedures may falsely elevate results. They're not recommended for use within 30 days of a blood transfusion unless the transfusion is leukocyte reduced. And there are still uncertainties surrounding the differential impact of other modes of injury, such as drug toxicity, opportunistic infection, primary disease recurrence, and rejection. With future research, we will hopefully have an improved ability to differentiate modes of allograft injury, additional prospective data, and more data to support use in all organ groups, particularly liver transplant. Gene expression profiling provides insight into the overall activity of the immune system. The Human Genome Project was an international scientific research project with the goal of determining the base pairs that make up DNA and identifying and mapping the genes from a physical and functional standpoint. This project laid the groundwork for gene expression profiling in solid organ transplant, which measures the difference in gene expression for genes that have been determined to discriminate between allografts that are healthy and those that are experiencing subclinical rejection. Similar to the donor-derived cell-free DNA assays, I will be focusing on the clinical rather than analytical validation studies. AlloMap is currently available for heart patients and under research protocols for kidney patients, and TrueGraph is available in both kidney and liver patients. The CARGO study first evaluated the role of gene expression profiling in discriminating IS-HLT grade 0 rejection from grade greater than or equal to 3A or moderate to severe rejection. This study utilized an 11-gene real-time PCR test that was derived from a set of 107 patients who provided 145 samples, and then converted this into a score of 0 to 40 and validated it prospectively in an independent set. Gene expression profiling distinguished biopsy-defined moderate to severe rejection from no rejection in the validation set and had an 84% agreement with IS-HLT moderate to severe rejection. Patients who were more than a year after transplant with scores below 30 were found to be very unlikely to have grade greater than or equal to 3A rejection, with a negative predictive value of almost 100%, leading to the conclusion that gene expression profiling is able to detect the absence of moderate to severe rejection and avoid biopsy in certain settings. The IMAGE study demonstrated the clinical utility, rather than validity, of AlloMap in a multi-center randomized control trial of 602 heart transplant recipients between months 6 and 5 years who were randomized to either continued surveillance biopsies or monitoring with AlloMap. There was no difference in composite rejection with hemodynamic compromise, graft dysfunction due to other causes, death, or retransplantation between the groups at 2 years. Patients who were followed with allograft underwent about 0.5 biopsies per year compared to 3 biopsies per year in the biopsy monitoring group, and this was statistically significant. Supporting the AlloMap monitoring in patients who were more than 6 months out from heart transplant was not associated with an increased risk of adverse outcomes and actually was associated with fewer biopsies. The e-IMAGE study was another clinical utility study that was very similar to the previous one, but looked at patients between months 2 and 6 post-transplant rather than 6 months to 5 years. This was a single-center randomized trial of 60 heart patients, and 3 patients in the gene expression group versus 5 patients in the biopsy group experienced the composite outcome of death or retransplant, rejection with hemodynamic compromise, or graft dysfunction, which was statistically non-significant, supporting that AlloMap at day 55 post-transplant was comparable with biopsy for rejection surveillance in heart transplant patients, and it may have the benefit of guiding corticosteroid weaning. Subacute rejection impacts about 35% of kidney patients within the first 2 years of transplant and has significant implications for long-term survival. Friedwald and colleagues conducted a prospective, multi-center observational study of 307 kidney transplant recipients who underwent surveillance biopsies at 2, 6, 12, and 24 months. These patients were classified into clinical phenotypes including subacute rejection and stable renal function, or no histologic rejection and stable renal function. 72 to 75% of patients with a negative biomarker results correlating with the absence of subacute rejection, and 25 to 28% of patients had a positive biomarker result correlating with the presence of subacute rejection. Clinical phenotype and biomarker correlated with the occurrence of decreased EGFR, IFTA, development of de novo DSA, and lack of response to treatment, supporting that blood-based biomarker use reduces the need for surveillance biopsies and has the potential to improve kidney transplant outcomes in the long term. The TrueGraph liver validation study is probably the most appealing for pharmacists, as it evaluated the role of gene expression profiling to enhance clinical judgment to guide immunosuppression modifications. This was a prospective, multi-center observational study of 186 liver transplant recipients with blood gene profiling samples that were again paired with biopsies showing either acute rejection, acute dysfunction with no rejection, and stable graft function samples. Serial sampling was then performed prior to acute rejection, prior to acute dysfunction with no rejection, during stable graft function, and after rejection treatment. Gene expression was analyzed to create a training set distinguishing acute rejection from no acute rejection. The algorithm and threshold were tested on the validation and yielded a sensitivity of 0.77, specificity of 0.82, and a positive and negative predictive value of 0.47 and 0.87 for acute rejection versus no acute rejection, leading to the conclusion that TrueGraph is a biomarker diagnostic for acute rejection that can be detected prior to graft injury, with the potential to provide serial immune monitoring for use in liver transplant. While the donor-derived cell-free DNA assays were more similar in design and interpretation, the gene expression profiling tests are not. AlloMap provides clinicians with a score from 0 to 40 related to the positive and negative predictive value that a patient is likely to have moderate to severe rejection. TrueGraph provides clinicians with an evaluation of how activated the immune system is, classified as transplant excellent or immune quiescent, and not transplant excellent or immune activation. Again, all assays are performed on blood samples, and the AlloMap has a turnaround of 2 days, while TrueGraph has a turnaround of 7 days. Again, Medicare and most commercial insurances cover all of these assays. Similar to the donor-derived cell-free DNA assays, all of the tests are intended for serial monitoring, make it important to obtain a baseline test and interpret the data over time. AlloMap has utility in monitoring risk for rejection and immune response over time to assess the risk of over immunosuppression and under immunosuppression. And it's currently only validated through year 5 post-transplant, though data to extend this is forthcoming. TrueGraph Kidney detects subclinical rejection, and it unfortunately is not validated for use until 90 days post-transplant or in patients with history of previous non-renal transplant, HIV, BK nephropathy, or nephrotic proteinuria. It was also validated in centers who had protocol biopsies, so it is recommended for use only in these populations. TrueGraph Liver guides immunosuppression minimization, and it's not validated for use, again, in patients who have previous multi-organ transplants or who are infected with HIV. Hopefully, these studies will continue to be studied across all organ groups, and with more data, we will be able to utilize these assays in the setting of other causes of graft injury. Additionally, we will have more studies that closely identify the relationship between immunosuppression variation and gene expression variation. In addition to the previously discussed biomarkers, there are other biomarkers under investigation that help in the diagnosis of kidney and liver disease, and most importantly for transplant pharmacists, in predicting renal recovery both before and after liver transplant, which may provide us with additional data to guide immunosuppression selection during the post-transplant period. Up until this point, our field has been stuck in sort of a Goldilocks trial and error situation, where we have patients who develop significant infections who we realize are over-immunosuppressed, or rejection due to under-immunosuppression. Serial monitoring may provide insight into the overall degree of immunosuppression to allow clinicians to monitor and adjust immunosuppression in a personalized manner. In the long term, these adjustments can allow for minimization of long-term toxicities and potentially decrease the risk of opportunistic infections to improve long-term outcomes. Transplant pharmacists have a unique opportunity to play a key role in utilizing these tests in clinical practice and further identifying their use within transplant research. Thank you again for the opportunity, and I'm happy to take any questions.
Thank you so much to both of our speakers, Dr. Tsunoda and Dr. Joyal. You both did an excellent job, and this was really a very interesting talk. So we did get some questions come through in the chat. So the first question is for Dr. Tsunoda. The question is patient financial burden still a realistic limitation since the costs for genotyping are approaching the cost of 2 tacrolimus blood levels?
Sure. Thanks for the question. So that was a kind of a quote from one of the physicians who was concerned about that. So I think, again, a lot of these concerns just go back to education. And I think that whole education falls on our shoulders, or, I think it's a something that us as transplant pharmacists should take on in terms of educating our providers and our patients about the nuances of doing pharmacogenomic testing, because things are rapidly changing. And I think we are the ones who have the knowledge to provide that education. And so I think really the results of our study showed that there was a lack of education and a lack of knowledge on clinical utility, financial burden, all of those kinds of things. So I don't know, I hope that I answered that.
It looks like there is a follow-up question. What is the financial impact of the overall transplant cost of implementing serial biomarker monitoring within the first year post-transplant? It appears that that question is directed to Dr. Joyal.
That's a great question. I think from the patient perspective, fortunately, all of the assays to date are covered by Medicare and most commercial insurances. So it would not be the patient fronting that burden. From a center perspective and insurance perspective, I'm not sure of the exact cost of each of the tests without that coverage. But I think that the benefit of those tests outweighs any potential cost that we incur from trying to treat rejection or opportunistic infections and the readmissions and downstream sequelae that come from those events.
So much. I wonder if you might be able to speak in some part if you've used these non-invasive diagnostics personally, sort of how you are able to use that in your own clinical practice, and if any of them have been a tool that you've been able to utilize in your own practice with regard to management of immunosuppression or, monitoring rejection therapy or anything up to that extent.
Unfortunately, in my current job, we haven't adopted their use yet. As a PGY1, I was able to use them in my heart transplant rotation. We used AlloMap to help guide immunosuppression decisions. And in PGY2, I was able to use AlloSure in more of a research setting, looking at the correlation between the coefficient of variation of tacrolimus with AlloSure. But unfortunately, we did learn a lesson that the TAC levels and the AlloSure do need to be drawn on the same day, and our patient population was too small to really draw any significant conclusions.
Thanks so much. We do have 2 minutes left if anybody else has any additional questions. Oh, we've got another question in here. Are AlloSure, Prospera, and TRAC all using the same single nucleotide polymorphism profiles? If not, how much do they vary?
They do not use the same SNP profiles, and they all vary significantly. AlloSure has the broadest SNP profile. Prospera's is more limited, and again, it was only validated retrospectively, and unfortunately, there's not a lot of information about the TRAC SNP profiles, so I would be curious to learn more, and hopefully with further research.
And have you seen any data that uses any of these therapies, or I should say diagnostics, in conjunction in your mind and your practice so far? Can you see a utility of utilizing donor-derived cell-free DNA with gene expression profiling? Do you find them to be complementary or redundant, I guess is the question.
I think that they are complementary, and I think that for AlloSure and AlloMap, they definitely are trying to market them as heart care and kidney care with use of AlloSure and AlloMap in both kidney and heart patients. So I think in the ideal setting, we would use both together rather than one on its own.
And Dr. Tsunoda, do you have any kind of final words on where you see genotyping going in the future with relation to immunomodulation as well?
Yeah, it's a tough question. I think I see that we kind of have an uphill battle in terms of clinical implementation. I know that we're interested in starting clinical implementation, but we haven't yet. COVID has put a little wrench in that. But I think we have a lot of education to do with our colleagues. Many of us may feel that we know the data well enough and can speak to it and feel that it's something that could be beneficial for our patients. On the other hand, we are all used to doing TDM and monitoring kind of after the fact. And with the exception of CYP3A5, there haven't been any other significant genetic variants with the other genes and drugs that rise to the level of us, using pharmacogenomics to modify our drug dosing with immunosuppression. So, I think we're still evolving, and it's going to fall on, it's going to be a lot of education, and we're going to need more research before it's going to hit kind of prime time.
Well, thank you both so much again. We're just at 2:01 p.m. Central Time at the moment. I really am so grateful for your time and your expertise and for taking the time to join and answer these questions. Again, this will be recorded and available to those who are interested in doing it again or sharing with their colleagues. Thank you all for tuning in. And again, thanks again to Dr. Tsunoda and Dr. Joyal.